Welcome to The Explainer. Today, we are diving deep into a skill that is absolutely essential, lung auscultation. Now, if you're learning this for the very first time, or maybe you're gearing up for an exam, this is for you. We're going to create a super clear, structured guide to help you master the sounds of breathing. Okay, let's dive right in.
So here's our game plan. We'll kick things off with the fundamentals, what auscultation is, and crucially, where to listen. Then we'll get a solid baseline by understanding normal sounds. And from there, we'll get into the good stuff, categorizing all those abnormal sounds and figuring out what they actually mean.
All right, first things first, we've got to define our core concept and really get a handle on the anatomy.
So, what is auscultation? It's actually pretty simple. It's just listening to the sounds inside the body. And for us today, it's all about tuning our ears to the lungs to figure out if what we're hearing is normal or if something's up.
Okay, before you even think about listening, you have got to know where each lung lobe is. This is so critical, especially if you're trying to track down a problem like pneumonia. Knowing these landmarks is half the battle, for sure.
Right. Now that we've got our map down, let's talk about what we should be hearing. See, you can't spot the abnormal until you've absolutely mastered the normal. So let's establish that baseline. Think of this table as your ultimate cheat sheet for normal sounds. What's so interesting here is how the sound changes as you move. Right over the big central airways, it's loud and harsh. But as you move out to the edges of the lungs, the lung tissue itself acts like a filter, making the sound much softer, almost like a gentle rustle. Okay, we've got our baseline down. Now we can start exploring the first category of abnormal sounds. Let's talk about the ones that are continuous and kind of musical.
So what do we mean by continuous? Well, think of these like a prolonged musical note, not a short little pop. They're drawn out. The real key to telling these apart is the pitch. The pitch tells you a story about the location and the cause of the problem. A high-pitched whistle, that usually means the smaller airways are narrowed. But a low-pitched, snoring sound, that points to secretions, like mucus, hanging out in the larger airways.
But what if you don't hear that wheeze all over? What if it's just in one single spot?
A localized wheeze is a whole different ballgame. Unlike the widespread wheezing you hear in something like asthma, a single, fixed wheeze suggests a physical blockage in one specific airway. This is a red flag, and the big takeaway is that this finding always needs a closer look.
Okay, let's switch gears to our second category of added sounds. These are the short, explosive, non-musical ones.
Yep, these are the famous crackles you always hear about, and they basically come in two main flavors, coarse and fine.
For crackles, timing is everything. Coarse rails, the louder, lower-pitched ones, they tend to happen early in the breath. But fine rails are different. They're softer, higher-pitched, and you hear them right at the very end of inspiration as those tiny little air sacs pop open.
This is such a classic and honestly perfect way to remember the sound of fine rails. Just rub some hair next to your ear. It's that delicate, crisp sound.
Now, if you ever hear crackles that are really loud and dry and sound just like Velcro being ripped apart, your brain should immediately go to lung fibrosis. This is a super high-yield fact, especially for exams.
The sound is totally distinct because it's not coming from the airways at all. It's generated in the lining of the lungs when those inflamed surfaces grate against each other. It sounds like two pieces of leather rubbing together, and it often comes with a sharp pain. Okay, last section. Let's connect all these sounds to a final diagnosis by adding one more really cool technique, listening to how the patient's voice actually travels through their lung tissue.
Well, when lung tissue gets dense, like in pneumonia, it's not filled with air anymore. And it turns out that dense tissue transmits sound way more clearly than healthy, air-filled lung. So, how can we test for that?
With bronchothony, you have the patient say 99. Over a healthy lung, those words would sound all muffled, but if you're over an area of pneumonia, they suddenly become sharp and distinct.
This one is fascinating. The patient says E, but what you hear through the stethoscope sounds like A. That sound change from E to A is a very specific sign that points right to lung consolidation. Now this is a powerful one. Normally, you should not be able to make out whispered words through a stethoscope at all. So if you can hear them clearly, that is a huge indicator of dense, airless lung tissue right underneath. So let's put it all together. Here's the crucial point. If you're listening out in the lung periphery and you hear loud bronchial breathing where you shouldn't, plus you get positive bronchophony and pectriloquy, you have a really strong case for consolidation.
By systematically going through these principles, mapping the lobes, nailing down the normal sounds, and then categorizing the abnormal ones, you've built a seriously powerful diagnostic framework. So now, it's time to put it into practice.